In this video, we are going to see the ophthalmoscopic characteristics of retinopathy associated with malignant hypertension. This is the case of a 43-year-old male patient with malignant arterial hypertension and hypertensive encephalopathy. Optic disc swelling in arterial hypertension will always be considered the highest degree of hypertensive retinopathy, in whatever classification we use. It is a marker of severity and represents the ocular manifestation of hypertensive encephalopathy. Without treatment, the life expectancy of these patients is 8 months. The mortality rate in the first year amounts to 80%. At 3 years, it reaches 94%, and it is 99% at 5 years. Only 1% of patients with this condition will survive 5 years. This is why the effective establishment of hypertension treatment is a vital urgency in these cases. Remember, optic disc swelling is the ocular marker of hypertensive encephalopathy. Ophthalmoscopically, in optic disc swelling, we see a decrease or disappearance of the physiological optic disc excavation. The sharp edges of the normal disc also disappear. They are now blurred, and it is difficult to delineate the optic disc contour. Simultaneously, due to edema, the margins of the optic disc are also raised. The neuroretinal ring appears swollen and hemorrhagic. And the edema and hemorrhages of the neuroretinal rim diminish or completely eliminate the vision of the course of the vessels as they enter the optic disc. Ophthalmoscopically, heart exudates appear as small white or yellowish-white deposits with sharp margins. They often appear as if they are made of wax, shiny or glittery. They can be arranged as single dots, confluent patches, sheets, rings, or crescents. They are composed of lipoproteins, lipids, and protein material, such as fibrinogen and albumin, that extravasate after the inner blood-retinal barrier is broken. They will be deposited mainly in the outer plexiform layer of the retina. Thus, in the pathogenesis of heart exudates, we see a double origin. First, heart exudates are due to increased vascular permeability, which allows fluid and lipoproteins to leak into the retina. Subsequent resorption of the edema commonly results in the precipitation of the lipid residues within the outer plexiform layer. Secondly, the paralysis of the axoplasmic flow at the level of the ganglion cells, whose axons form the nerve fiber layer of Henle, is also involved. The stopped axoplasmic flow hinders the transport and drainage of the waste substances, thus favoring their accumulation in the Henle layer. The formation of the macular star is due to the deposit of heart exudates around the macula, adopting a characteristic radial or star-shaped pattern. The soft exudate or cotton wool spot should not be called exudate, because it is actually an ischemic edema of the retinal nerve fiber layer and not an exudate. It represents an infarction of the retinal nerve fiber layer due to an occlusion of a terminal arteriole due to arterial necrosis. Remember that the cotton wool spot represents the ocular marker of the malignancy of arterial hypertension. When the cotton wool spot appears, the parenchyma of the target organs of hypertension, brain, heart, kidney, is suffering severe damage. Splinter or flame-shaped hemorrhages are a subset of retinal hemorrhages, which are located within the nerve fiber layer of the retina. They have a directional value since they are oriented following the path of the ganglion cell axons towards the optic disc. Dot and blot hemorrhages are found deeper in the retina than flame-shaped hemorrhages or splinter hemorrhages. Usually in this case, the blood collects in the outer plexiform or inner nuclear layer. Each configuration is due to retinal compression, restricting hemorrhages to a specific place. They are easiest to see in the peripheral retina, where the nerve fiber layer is thinnest. Dot hemorrhages are or resemble microaneurysm. We must differentiate them, although sometimes it can be difficult, and fluorescein angiography might be necessary to distinguish them. In this case, we can see dilated, thickened veins with a greater caliber. This is caused by the stagnation or difficulty of passage of the venous blood column at different levels. At the level of the optic disc due to edema, and also at the level of pathological arteriovenous crossings, arteriovenous nicking. We also see the relationship of the arteriovenous caliber altered. This is due to the decrease in the ratio between the caliber of the artery and the caliber of the vein. The causes are two: the increase in the venous caliber, as we have seen, and the decrease in the arteriolar caliber, due to the vasoconstriction of the arteriole. Arteriovenous nicking is the phenomenon where an arteriole is seen crossing a venule, which results in the compression of the vein and alterations in the venous blood column. It is thought that, since the arteriole and venule share a common adventitia at the level of the arteriovenous crossing, the arteriole's thicker walls and the greater pressure of its blood column push against the walls of the venule, forcing the venule to collapse. Other theories suggest that this results not from compression from the arteriole, but from sclerotic thickening or glial cell proliferation at the site where the two vessels cross. Here we can see bonnet sign circumambulated, which is made up of the following triad. An arteriovenous nicking, associated in the vicinity of the crossing with a cotton wool spot, and retinal hemorrhages. Here we can see the retinography of the right eye of the clinical case. And here you can also see his left eye. Thank you so much for your attention.